Hello, this is part 4 of the Neuro Unit. In this section, we're going to talk about inflammatory brain conditions. The first inflammatory brain condition we're going to cover is meningitis. This is an acute inflammation of the meningeal tissues surrounding the brain and spinal cord. These are often secondary to viral respiratory diseases. Those most at risk for contracting meningitis are people who live in confined quarters such as dormitories or institutions. Meningitis can be bacterial or viral in nature. You can see that there's a significant difference between bacterial meningitis and viral meningitis. Bacterial has near 100% mortality if left untreated, whereas viral is usually self-limiting and has a good prognosis. We're going to focus on the nursing care for bacterial meningitis because it can be so deadly. The key signs of bacterial meningitis are a high fever, a severe headache, nausea and vomiting, and nuchal rigidity or neck stiffness. Your patient may also complain of photophobia, have a decreased LOC, show signs of increased ICP, and have a new onset of seizures. Meningococcal bacterial meningitis has a distinct skin rash, and petechiae may be present if septicemia has occurred. Here's a video of the glass test.
Meningitis is an infection of the fluid that surrounds the brain and the spinal cord, and it can spread from that fluid into the brain itself. And it can be a really dangerous condition that can cause long-term damage to the baby's developing brain. There are lots of different causes of meningitis. It can be a virus or a bacteria. And the one we're going to talk about now is one meningococcal meningitis, which is associated with a very characteristic rash. So you may know about the glass test. And that's a test where you can press the side of a glass against the spot of the rash on your child's skin. Usually, in rashes, and they're very common in children, that spot will disappear when you press it, and you'll be able to see that through the side of the glass. If you press the spot and it doesn't go away, that's called a non-blanching rash. And a non-blanching rash in a small child is a worrying sign. And that's something where you should immediately take your child along to see the GP or to your local emergency department. Way back in 1999, my son Thomas, he was at nursery in the morning, and I picked him up, I think maybe 12 o'clock, is one of those where you go at 9 and finish at 12. And he was complaining that he was feeling tired, and it was, oh, my legs are tired, my legs are tired. I'd be, oh, come on, Tom, stop being silly, because sometimes you'd be a bit lazy. But no, Mum, my legs are tired, my legs are tired. Got him home, and he went straight to bed, which was quite unusual for him. And later on that afternoon, his father came back, and I said, oh, Tom's been feeling a bit funny, and he's been asleep for a long, long time. So we took his temperature, and it was extremely high. And we called up the doctor, and they said, well, just keep an eye on him. And he woke up a bit later, and yet again, he wasn't looking right. He was feeling, and it just didn't seem right. And if I remember then, Alex phoned up his mother, and she said, oh, I think maybe you should, maybe go to the doctor. And then we saw the rash, and only a few spots on his chest, not really spots, but bruises, tiny little deep red marks. And at that point, we panicked, and it was late. At this point, it was fairly late at night, and jumped in the car. I drove like a mad woman. Alex in the back, went through every single red light, hand on the horn, and drove to St Mary's. Alex took him straight up. I had to park. Within literally seconds, there was about 6 doctors around him, and they weren't quite sure really at this point what it was. And then that was it. Within 10 minutes, no more than that, he was up in intensive care. And it was meningococcal septicemia, which is the highest form of meningitis. And even to the day, they said if we were lucky that we got nearer to St Mary's, because St Mary's is the hospital for meningitis. And we were lucky that we went there straight away. If it'd been an hour later, without a doubt, he would have been dead.
and I'm very pleased to tell you that Thomas is now healthy and survived a horrible, horrible, horrible meningitis.
That video just goes to show you don't want to fool around with bacterial meningitis. Let's go on and talk about nursing implications. We want to do frequent vital signs, perform a comprehensive neuroassessment, and again document baseline findings, assess intake and output, and perform a respiratory and skin assessment. Respiratory because the patient may have altered respirations, and he may have an altered level of consciousness. The skin assessment is important because we're looking for that characteristic rash and petechiae that go along with bacterial meningitis. The assessment for a patient with suspected bacterial meningitis should be done quickly and efficiently because time is so critical. The goal is rapid antibiotic administration once bacterial meningitis has been identified. A CT scan may be performed, but the ultimate diagnostic tool for bacterial meningitis is a lumbar puncture. You may want to refer to Table 56-16. With bacterial meningitis, the white blood cell count of the CSF is high, greater than 1,000, whereas with viral meningitis, it's lower. Also notice with bacterial meningitis, the appearance of CSF fluid is turbid or cloudy. When you see the fluid and it's turbid or cloudy, you should automatically think bacterial meningitis until it's ruled out otherwise. Viral can also be cloudy, so the appearance is not definitive, but it can give you a good idea of what to do until you get the full results back. The glucose levels are also low because bacteria feed on glucose, whereas the viruses do not. There's some possible nursing diagnoses for the patient with bacterial meningitis. Notice again that cerebral perfusion, increased ICP, and cerebral edema are common problems. Also, we want to look at temperature. There may be hyperthermia related to infection, and the patient may have acute pain related to headache or muscle aches. Our goals for the patient is to resume maximal neurological functioning. We want the infection to resolve and the pain to be under control. Now let's look at some interventions. Prevention is really important. We want to prevent the development of bacterial meningitis. This includes promoting immunizations for pneumococcal pneumonia, influenza, and 2 meningococcal vaccines to prevent bacterial meningitis. The 2 meningococcal vaccines are MPSV4 for age 55 and over, and MCV4 for age 55 and below. We want to educate the community to seek early and vigorous treatment of respiratory and ear infections. Be aware that bacterial meningitis is extremely contagious and is spread through respiratory droplets. Therefore, any patient with suspected bacterial meningitis, remember neck rigidity, changes in LOC, fever, cloudy CSF from a lumbar puncture. These patients should be placed in respiratory isolation, so wear a mask. And you as a nurse should take all droplet precautions also. If the patient has any close contacts, those individuals are encouraged to take prophylactic antibiotics. You'll notice again here our goal is to decrease cerebral metabolism and edema. We have to be vigilant with temper regulation. Acetaminophen or aspirin may be used to reduce fever. Also consider cooling blankets or tepid baths, but be sure to avoid shivering. Patients are also at risk for seizures, so implement seizure preventative methods such as minimizing stimuli, patting the side rails, and administering anti-seizure medications such as Dilantin or Keppra. You also have to keep an eye on the patient's fluid and electrolyte balance. These patients are running very high fevers, so dehydration is always a possibility. Monitor their eye and nose very carefully. Calculate fluid replacement based on adding 800 milliliters per day plus 100 milliliters for each degree of temperature greater than 100.4 degrees Fahrenheit. Nutrition is also important. We need to meet metabolic needs, and we may even need to consider enteral nutrition. Next, we want to promote the patient's comfort. They may have severe headaches. Codeine often is used for these really bad headaches. We want to position the patient in a position that's most comfortable for him. Sometimes a fetal position with the head extended may work. Keep the head of the bed elevated 30 degrees. We also want to reduce stimuli, and perhaps cool compresses to the eyes may help. The patient will need several weeks of healing before resuming normal activities. During this time, teach the patient the importance of appropriate nutrition. Stress a high protein, high calorie diet in small, frequent meals. Encourage the patient to increase their activity as tolerated, because a lingering headache and a stiff neck that may radiate back to the back of the legs may persist. The patient also needs to get adequate rest. Assess the patient for any residual effects, such as problems with vision, hearing, cognitive skills, or even motor sensory dysfunction, and make the appropriate referrals as needed. We want to evaluate the patient to make sure they have appropriate cognitive functioning, that they're oriented ×3, that they maintain a normal body temperature, and that their pain is controlled and they will report additional pain. Next, let's look at viral meningitis. Very quickly, I'll highlight some of the more important aspects of viral meningitis. You remember from a few slides ago, viral meningitis is self-limiting and has a good prognosis. Treatment is aimed at symptom control. These patients present with similar clinical manifestations as bacterial meningitis, such as headache, fever, photophobia, and stiff neck. A lumbar puncture is again used for diagnosis, and you might want to refer back to Table 56-16 for the differentiating aspects of the CSF fluid. Also, the CSF will be sent for a test called an expert EV test, which will produce results within hours. Immediately after an LP, if the CSF is cloudy, antibiotics should be administered until bacterial meningitis is ruled out, because bacterial meningitis is so lethal. The antibiotics can then be discontinued once the CSF results are back and you know what you're dealing with. Again, these patients usually have a very good prognosis and usually make a full recovery. The last inflammatory condition of the brain we'll discuss is encephalitis. This is an acute infectious inflammation of the brain, and it's usually caused by a virus, but can also be caused from bacteria or a fungus. They're classified into epidemic, which is caused by ticks and mosquitoes. Think West Nile encephalitis. And non-epidemic, which is caused by another infection such as measles, chickenpox, mumps, or herpes simplex virus. HSV is the most common cause of non-epidemic encephalitis. The clinical manifestations of encephalitis are pretty nonspecific. The patient can complain of fever, headache, nausea and vomiting, and can have minimal changes in mental status, or they could progress into a coma. Virtually any CNS abnormality can be found, such as hemiparesis, tremors, seizures, personality changes, memory impairment, amnesia, or dysphagia. Again, look at the table 57-16 and take a look and see how the CSF differs from that of bacterial and viral meningitis. Sorry, that's 56-16. The common imaging scans can also be performed, such as CT, MRI, or PET scans. There is a test called a PCR test that can detect HSV and West Nile virus. Suspect West Nile in adults over 50 years old that have encephalitis in summer or early fall. The nursing management of encephalitis is aimed at health promotion and supportive care. Teach the public about the importance of mosquito control. Drain standing water. Avoid being out around dawn and dusk. And use insect repellent for mosquitoes and ticks. Provide supportive care with antivirals if the patient has an HSV infection. Also, you may want to institute seizure precautions, such as a non-stimulating environment, and perhaps even seizure medications. Methods to prevent an increase in ICP we have already covered in past units. This is the end of Nursing Management on Inflammatory Brain Conditions, Part 4.